So, without further ado, let's talk a little bit about propranolol. As Professor Routledge said earlier, it's a drug that's been around a really long time since the 1960s, and is generally an effective drug. And I suppose I'm going to take the starting point as an investigation that was carried out in 2020 by the Health Service Safety Investigations body. And this really came to light regarding a case which maybe highlighted that we hadn't really considered as a system and as a wider level about the dangers of propranolol. So this was an extensive investigation to look at an unfortunate case. So January 2018, Emma had taken an overdose of propranolol and citalopram at the same time. And she'd phoned about 7 o'clock. She was alert and responsive, and the ambulance actually arrived quickly, quickly, but within an hour. However, on arrival, Emma unfortunately deteriorated very rapidly, and advanced life support, cardiopulmonary resuscitation, etc., had to be instituted on scene. She was transported to the hospital at 9 o'clock when they managed to try and stabilise her, and unfortunately, on arrival in the hospital, she was pronounced dead. So a really tragic event. But at least it made somebody think about, is there something more that we need to think about this particular medication, and is it something that needs to be done? And I think this case does also highlight is the rapid nature of or onset of deterioration from this drug. So from 7 o'clock in the evening, well, not well, but alert, and it was only a matter of hours later when this young lady was declared dead. And I think one of the key things, and we can see that there is this ongoing recognition of this drug being potentially problematic. And in this talk, I'm just going to talk through a little bit about that, and a little bit about the kind of the background, and a little bit what we're seeing in the National Poisons Information Service. So what is propranolol? Well, I'm in an audience of pharmacists and clinical pharmacologists, so I'm probably not going to labour this point. But essentially, it's a non-selective beta-adrenoreceptor antagonist. Primarily, it works on the heart, but it has also some effect on the blood vessels. I think it's important to say from a pharmacokinetics point of view, it's got high bioavailability, which means just means it's well absorbed. It's got a high volume of distribution, so it's well spread throughout the body when it's taken. So means that treatments we can use for some toxins such as dialysis, hemodiafiltration, etc., aren't really appropriate because it distributes widely throughout the body. And with the immediate release preparation, it has a half-life of up to about 6 hours, but modified release up to about 20 hours, and it's primarily excreted in the kidney. And as a clinical pharmacologist, I always have to put up a picture of what it looks like, its chemical structure, which you can see there. So we can see, I suppose, a couple of things to take home already from this, that it's widely distributed. It crosses the blood-brain barrier, unlike a few other beta blockers. It's not really a candidate for removal by any other treatments such as hemodialysis or hemodiafiltration, and the modified release preparation hangs around for a very long time. Generally, in pharmacology, we'd say that 5 half-lives is your time to elimination of a substance. So if we take the upper end of that, that's 100 hours. So you're talking just under 5 days for a complete elimination. And I think Emma's going to talk on this a little bit more. But I think the key thing to say, there's actually quite a lot of indications in the BNF for propranolol use. We've maybe all at some point come across patients with thyrotoxicosis and potentially migraine prophylaxis and propranolol. But I would argue, and I think Emma's going to make this argument, that it's really that bottom one in red is actually the license for propranolol that we have in the BNF around anxiety. I want to talk a little bit briefly about the National Poisons Information Service. I'm going to talk a little bit about the calls and inquiries. So, what is the National Poisons Information Service? So, some of you are aware of TalkSpace. Are you aware? You'd say yes or no. What is it? So, TalkSpace is really useful. Um, it is a clinical database giving you guidance on not only pharmaceutical compounds, snake bites, spider bites, um, other chemicals that you could come in contact with, and how to manage them. So, step by step, allows access to healthcare professionals. So, it's not just doctors, paramedics, nursing staff, pharmacists, of course, as well. So everyone can access and gives you a step-to-step guide. And it's the National Poisons Information Service that is really responsible for the content and that guidance. If you get to a situation where you're not entirely sure or you're not, something slightly different goes on, you can contact. We've got a phone number. You can contact. You'll speak to a specialist. Who are from a scientific background, and that could be a nurse background, pharmacist background, life sciences background, who will give some advice. And if that advice is, or the case is difficult, they're severely unwell, such as if we were called about Emma at the start of the case, then that would be an automatic consultant referral where you'd have the misfortune of speaking to me or maybe one of my more capable colleagues, Dr. if it was in Cardiff, Dr. Alison Thomas and Professor James Coulson, and we'd give you some advice tailored to that particular case. So essentially, I think it's just important when I'm presenting this data. So Talkspace access first. Oh, I'm not really sure. Phone call initiated, which is logged as an inquiry, and we take the clinical case data. And if it's a little bit more complicated than that, then we get the consultant involved to give a little bit more advice. So looking at Talkspace, we can see that it's pretty in terms of page view. So this is the last kind of financial year, 20, sorry, the year before, I should say. And so number 6. So if you compare, top of the tree, of course, is paracetamol, which is still by far the most common cause of contact with our service. But we can see that we're getting quite a lot of page views. So this is suggestive, and some studies have suggested that the amount of a medication that's available in the community will relate to Talkspace accesses. So it's a common thing that people are looking at, healthcare professionals. And then telephone inquiries. So as I said, this is the next stage. So if a little bit unsure. So I would say that these inquiries generally will be a little bit more problematic, maybe a little bit more severe, because someone's decided that there's not enough information here on the Talkspace sheet. I need to get a bit more guidance. And then it's number 9 in telephone inquiries. So usually we could maybe take this as a slight surrogate of severity of overdose. And then in hospitals, we can see that we're getting a lot of calls from our hospitals, and these will generally be from the nursing staff, pharmacists, emergency department doctors, ITU consultants at scene. So that's almost 300 inquiries from hospitals alone. And then consultant referrals. So these are, as I said, generally the more complicated cases. These are the patients who are unfortunately in cardiac arrest, are seriously unwell. These calls will tend to come from the emergency department in the resus environment, or potentially in the intensive care environment where extra or additional adjunctive treatments or adjunctive advice is needed. And it's just quite marked there that it's number 4 on the list there, just suggesting there is an increased severity of these propranolol calls. So, and what we can see is if we look at calls to the poison service about propranolol year on year, we've seen an increase. It's a little bit of a wavy line, but I think if we take a crude line at 400 in 2017, we can see that we're up to 600 calls in 2024. Okay, so a 50% increase. So it's a problem, and these, of course, as I said, are calls or inquiries to NPS. So these are more severe, generally these more severe cases. So as I said to you, why is it such a problematic drug? Well, it has a few properties. We talked a little about the beta blocking effect. So as I said, that's going to cause your heart not to work very well, decreased contractility. It also, I'm not really going to go in detail about kind of the ion channels in the heart, but I think the key thing to say is that the movement of sodium ions is important to cardiac muscle contraction and excitation. And if you affect those channels, so you block those channels, you cause delays in that process, which can lead to arrhythmias, and those arrhythmias, of course, can cause toxicity. And propranolol has this effect on the sodium channels to increase the risk of cardiovascular arrhythmias. And also talked about it's widely distributed in the body, and this is due to the fact that it's lipid soluble, and therefore it can also cross the blood-brain barrier. So you can see depression, central nervous system depression with it, which you may not see with other beta blockers, and also significant risk of seizures. So we've got this kind of a little bit of a perfect storm with this medication, whereby you've got reduced cardiac contractility, your heart's not working very well. Your heart is also more likely in addition to the cardiovascular collapse that you're experiencing, is more likely due to sodium channel blockade to go into an arrhythmia, which will further worsen the cardiovascular output. And on top of this, you've got the CNS depression and risk of seizures, which can potentially be difficult to manage as well. So for all those reasons, quite a nasty medication. And I think this is the key thing, which just to highlight, I don't really want to go too much into treatment, but there are some treatments that we can use, but there is no really, I suppose you could say, direct antidote. But there are some specific treatments such as glucagon in beta blocker overdose, high dose insulin. And I think one of the things where there is sodium channel blockade is the use of things such as sodium bicarbonate, in my experience, can be quite effective to really use aggressively in managing these overdoses. So what about what we're seeing in terms of the often Office of National Statistics data and things? Unfortunately, this is quite a long time series here. This is English and Welsh data from the ONS. And as we can see, even though this drug has been around a long time, since the 1960s, we can take, bearing in mind, of course, that maybe data is captured slightly different, but way back in 1993, there were only 11 deaths due to this drug. And then now, here we are in 2022, we're talking about 70 odd deaths. And if you look at that graph, it's really since the turn around 2008, 2009 that we've seen this steady increase in deaths where propranolol was mentioned on the death certificate. So there's something happening here. And we're seeing this kind of recent change probably in the last decade or so, where propranolol is starting to cause these problems after a relatively kind of steady, unfortunate but steady baseline. And this is just data once again from this is English data from the Open Prescribing resource, which is fantastic. And this is just looking at primary care propranolol prescribing in England, and we can see this very clear pattern just on the absolute numbers. I don't think we need to do a kind of R correlation here. So 2019 to 2020, 5.7 million prescriptions, and in the space of 5 years, we're up to almost 7.5 million prescriptions. So a huge increase, proportional increase in prescribing of this medication. And we can see, and I think this is one thing that Emma is going to address in her talk, is that is a real prescription favors but I suppose is more common in female patients than male patients, and this proportion is pretty static. So it's a kind of 2/3, 1/3 prescription, and unfortunately that demographic is also reflected in mortality data. And of course, our index case that we talked about at the start, Emma, of course, is one of these people who also fits with that demographic. So we're seeing a proportion or a part of our population being really much more adversely affected by this particular medication. So I just want to give a big kind of shout out at this moment to the team at AWTTC, particularly Kat Chaplin, who very recently presented this data. And I think this gives a good kind of Welsh perspective. So in this graph, I think it's fairly explanatory. It goes from June 18 up until December of last year. And really, we can see this increase across all health boards within Wales. So this is something that is happening in England, and it's also happening in Wales. I think one interesting thing that, and this is a particular shout out to Dr. Catherine Chaplin, who's done a lot of work in this area trying to collect some statistics, is that it's difficult to draw an absolute conclusion and attribute causation or causality to this. But in the great work, I think it must be acknowledged, in reducing anxiolytic prescriptions, we can see that lorazepam and diazepam prescribing has continued to decrease in Wales, which I think is something to be celebrated. I think it's something that we've made great strides on. But is the question, have we diverted to propranolol? And we can see that propranolol prescriptions have been slowly increased in that very same time frame. So just something to think about. And I think we're right at the top of this morning, Professor Routledge was talking about this kind of complex knot, and I think sometimes we can try and unravel something somewhere else, but then it's almost maybe the little boy in Holland and the Dyke, and he's trying to fill all these gaps, and you keep it one, and then another thing comes. So I think there's something that maybe just describes, maybe we'll have a little bit more thought, and maybe also, as we've also touched on with Dr. Helen Cordy, we shouldn't just be thinking about the medication, isn't it? We should be thinking about the need, the holistics. What are the environments that make the needs for these medications? And it's just not the medication alone. It's about there's a societal issue and things. And once again, Emma may touch a little bit on that as well. So that's me. I was trying to finish about 11 for Emma. So I'm going to take a kind of worried look to Anne Coles to see that if Emma's online. But I think from me, propranolol is a useful medication. It's been around for a long time, and it has many license indications, including anxiety, where perhaps, as we'll touch on in the next presentation, it may not be the best option. What we can see is that its prescription is increasing, and really that's happening particularly over the last 10 years. And unfortunately, we've also seen this accompanied by an increase in deaths, where propranolol is listed on the death certificate. We have seen this pattern with decrease in lorazepam and diazepam and increase in propranolol. And maybe that's something that just also suggests to us that there's more work beyond just the medication, of course. It's a little bit about maybe an unmet need. And of course, I think Emma's going to touch on a little bit about things that she's done in Edinburgh to try and address this.